This is pharmacogenomics. It will help us to select the most suitable drug and dose to achieve a better therapeutic response. And pharmacogenomic variants affect an individual response to drug. And that is what determines the control of blood sugar, development of complication, and even the adverse effect. These are some of the things that determines our response to medication: the age, the gender, the combined disease, the liver, the kidney, drug-drug interaction, and genetic variation. And these differences in genetic makeup determine the drug metabolism that can affect our response to drug. Based on that, we now have poor metabolizer, intermittent metabolizer, and extensive metabolizer. I'm sure we are familiar with INH, the isoniazid, response, whether they are high rapid metabolizer or slow metabolizer. That determines those of them that will come down with neuropathy associated with INH. The same thing with this particular one. So what are the rationale for pharmacogenomics in diabetes? It is because of individual variability and precision therapy goals. Okay, so the pharmacogenomic study that have identified genetic variants that influence response to many of the drugs that we are using. And so tailoring treatment based on this variant can improve efficacy and reduce the risk of adverse effects. These are some of the genes that are responsible, or that are responsible for metabolizing some of these drugs. If you look at sulfonylurea, for example, we have ABCC8, we have KCNJ, and all that. And then for metformin, you can see CLC22A1. So the presence or the absence of any of these genes, will determine the response of the patient to whatever drug that you give to them. And so there are ethnic variations which are not taken into consideration when people come to present drug to us. And that is one of the reasons we must insist that whatever drug that is brought to be given to our patient there must be studies, done in Nigeria to know whether it will even work with us or not. Now, people are thinking about pharmacogenomic testing, and it is available. It's coming up in developed countries that you could actually profile somebody's genetic profile, and then based on the genetic profile, then you'll be able to know this drug. If I give it to this drug, if I give it to this patient, it will respond. If I give this particular one to the patient, will not respond. So that is the beauty of precision medicine and personalized medicine. So what is the pathway to personalized medicine? Once it comes to the patient comes to the hospital, you do the genetic profiling, which is not difficult to do, and based on the result, then you will know what drugs you will give to the patient based on the characteristic of that patient. What are the clinical applications? Genetic testing before therapy, and then it will optimize drug choice and dose. Are there any benefit for it? Of course, there are so many benefits. It's going to improve efficacy, reduce side effects, cost effectiveness, facilitate design and development of precision therapeutics, support stratified drug development, and the dosing strategy. The benefits also include prognostic accuracy, identify subset at higher risk of complication, and helps in the choice of therapeutic decision. Any limitation? Yes. Cost of genetic testing. As at now, it doesn't come cheap. Expertise in genomics, data science, and ethical and clinical medicine. In the practice of medicine now, we must embrace all different experts, data scientists, genomic experts, and all of that. We have limited availability, especially in low resource setting. Under representation of certain population. For example, we haven't done the genomics of type 2 diabetes in Nigeria. So it will be difficult to implement that as at this moment. Now, what are the role of multidisciplinarity? I've mentioned that we need to come together to be able to make it work. What is the future direction? Cutting-edge technology such as gene editing, CRISPR, which is the in thing now, which is one of the things that have been shown that can even be used, to manage patients with cancer. You know the gene that is defective, then you can cut it off, and then same with type 2 diabetes. We are able to identify the gene responsible for it. You can use CRISPR technology to do that, integrating novel biomarkers and then regenerative treatment. Other future direction, patient engagement is very important because they are important in decision management. In conclusion, heterogeneous nature of type 2 diabetes, as shown by molecular and genetic insights, required tailored approaches to enhance diagnostic precision and therapeutic efficacy. The genomic technology and multiomics in integration and AI technology. These possibilities are restricted by translational challenges, which include technical, ethical, and economic barriers. And overcoming the barrier requires multidisciplinary collaboration. Evolving landscape of precision medicine holds great promise for improving treatment outcomes. Continued investment in research, infrastructure, and policy development will be essential to realize this potential and minimize the benefit. Thank you very much.
We thank you most sincerely, Professor Lamoyegu. Please let's give me another round of applause. Thank you. I'm sure Dr. Odeniyi is ready for us.
Okay, so I'm going to be talking about management of adrenal tumor. Now, these are tumors that we don't see commonly. We all know about adrenal gland, we talk about Cushing's syndrome, and all that. I'm going to follow this outline, and then in the next 10 minutes or thereabouts, I should be through with this presentation. As I said, adrenal tumors are rare, and they can either be benign or malignant. And this tumor can either be functional. Most of the time, 60% of cases, they are functional. And when I say functional, that means they are producing hormone, whichever hormone that is resident in the adrenal gland. And 40% of time, they are non-functional. The key challenge here is in diagnosing this adrenal malignancy. Sometimes we have hormone excess, and we just say, oh, cortisol is high here, this must be Cushing's syndrome. But what is causing that cortisol? It will just be a tumor that is elaborating that. So, where the challenge also is to determine whether it is a malignant tumor, and treatment is also a problem. Most of these tumors are actually surgically amenable. The goal is to optimize patient outcome with individualized evidence-based management. So how do we classify adrenal tumor? I mentioned it earlier. It could be functional, and under the functional tumors, we have the pheochromocytoma, the Cushing's syndrome, primary aldosteronism, and the rare ones are the androgen and the estrogen secreting tumor. The non-functioning tumors are the incidentaloma. These are the ones that you just find incidental findings. They are not going to do any harm to the patient. Then the malignant tumors are actually adrenocortical carcinoma. So they arise from the adrenal cortex. I didn't go through the basic anatomy of the adrenal gland, where we know that we have the adrenal cortex and the medulla. Then we also have metastatic tumors. So it's not every time that the tumor is from the adrenal gland. So how do we evaluate this patient? A very good history is very important. Then we need to actually examine the patient for signs of hormone excess. Now, biochemical testing will be very, very important. Cortisol, and we all know how to evaluate a patient who we suspect will have excess cortisol production. Dexamethasone suppression test, urinary free cortisol, or we are using the late night salivary cortisol. We may need to measure the plasma urinary metanephrine when we suspect this could be a pheochromocytoma, and we also need to measure aldosterone-renin ratio if we are thinking of a patient who has hypertension and hypokalemia. Most of the time we are thinking about an aldosterone that is elevated in this individual. In endocrinology, we know that it's only when we have established that a particular hormone is high or low that we go for imaging, not the other way around. If not, we are going to waste the patient's money. So when we have confirmed that hormone is high or low, as the case may be, then we may go ahead and choose the imaging of choice. And this could be a CT, MRI, and this will show the size and all that. Now we could also do F18 fluorodeoxyglucose PET scan, or we do a PET/CT scan fusion. These are advanced techniques to actually pick this tumor wherever they are. And we also need to rule out metastasis in this individual. In terms of treatment modality, most of the tumors are managed surgically. And functional tumors, all except the mild subclinical cases, are treated through surgical means. What will make this make us suspect this could be a tumor? If the size on the scan is greater than 4 to 6 centimeters, then we're probably likely dealing with a tumor. If there is a rapid growth, if there is elevated urinary 17 ketosteroid. Now we remember that if we are investigating a patient for CAH, this is what we look out for: 17 hydroxyprogesterone. In tumor also, this is also elevated, and if the tumor have irregular or heterogeneous features, and there are other symptoms that we have that is linked to this tumor. So gold standard is to remove the adrenal gland, and approaches can be laparoscopic or open surgery. But there are pre-operative conditions that we must maintain and make sure that we do. In patients with pheochromocytoma, for example, the tumor that is elaborating excess adrenaline, we need to block the alpha receptor before we block the beta receptor, so that we prevent catastrophic hypertension. And for cortisol excess, we need to also give a stress dose cortisol pre-operatively, so that we don't have an adrenal crisis post-op. Then we need to also look at the hormones and the electrolytes and make sure that they are correct. In patients who have inoperable metastasis, then medical management is the way to go. Mitotain has been used for most adrenocortical tumor. There are other chemotherapy regimens that could be used. Etoposide, doxorubicin, cisplatin, and mitotain can also be used. And there are new targeted novel therapies that are still in clinical trial. I've mentioned about managing pheochromocytoma, alpha blockage before beta blocker. Now for functional adenoma, spironolactone with eplerenone may be useful, especially in patients with primary aldosteronism, if the candidate is not fit for surgery. And we can use ketoconazole, metiraphone for those who have symptoms of Cushing's syndrome. Incidentalomas are those tumors that are found incidentally. They are non-functioning tumors, and prevalence increases with age, but most times they are benign, and sometimes we assess for hormone secretion and malignancy risk. When they are less than 4 centimeters, like I said, the risk of malignancy is minimal. They are non-functional, and we need to repeat imaging and laboratory testing every 6 to 12 months. We can remove this surgically if the growth is increasing and if there is new hormonal activity or the tumor now develop a feature that is suspicious. After all this, we need to monitor and follow the patient up, and the follow-up is lifelong. And what are we looking for? We need to look for reoccurrence. We've removed the tumor. Is there a reoccurrence? And we must make sure that we do that. Are there changes in the hormonal function? What are the other cardiovascular and metabolic complications that will result from removing this tumor? The approach is multidisciplinary. We need the endocrinologist, surgeons, oncologists, radiologists, and the pathologist in care of this patient with adrenal tumor. The emerging trend is to have a minimally invasive robotic adrenectomy, and there are advanced imaging, like I mentioned earlier. Precision medicine is the way to go, and Professor Lamoye, I think it's good I came after him, because this is what we just spoke about. When we do precision medicine, we are actually looking at where is the problem, what gene is affected, can we go and change that, like we call gene editing, gene testing. All this need to be done. God has given us the knowledge to be able to do a lot of things now. Even human being gets edited. We will do BBL, this is body editing, and those are editing. Okay. So the key message to take away from here is that we need to evaluate hormone excess and malignant risk in all adrenal tumors. Surgery is definitive for functional and suspicious tumor. The non-functional incidentaloma often requires surveillance, and adrenocortical carcinoma need multimodal treatment, but we need to know that the prognosis is poor. Follow-up is lifelong and is quite essential. These are the references. Thank you very much.
Thank you very much, sir. Since you have advocated that we do body editing through BBL, that's a new one that we'll take away from here. Distinguished ladies and gentlemen, it's now time for us to ask those questions, those comments, and those things we want to. But just before then, I would ask that Dr. Hehe please give us a recap. Dr. Hehe, please. Thank you.
Thank you very much. I'll give a quick recap. We had three speakers: Dr. Nwodo, who spoke on precocious puberty, then Professor Lamoyegun, and Dr. Denny. Dr. Nwodo started by giving us a case presentation of a 6-year-old girl with central precocious puberty. She went through the epidemiology of PP, talking about the male-female ratio, and the prevalence, which she mentioned was between 1 in 5,000 to 1 in 10,000. She also mentioned the age of puberty, age of onset of puberty for females has been 10 to 11 years, and for males 11 to 12. She took us through the types of precocious puberty as being central PP or peripheral PP, the central type being idiopathic or pathologic. She also went on to talk about the causes of precocious puberty, the cause of CP being idiopathic or organic, that's central precocious puberty, and the peripheral type being either endogenous or exogenous. She took us through the differences between central and peripheral precocious puberty and talked about the treatment modalities after the clinical features and investigations. Of note is that she mentioned that X-ray of the wrist on the non-dominant hand is important, and diagnosis is made by the bone age advanced greater than 2 years. She mentioned the treatment considerations, whether to treat or not, and she gave the goals of treatment as to preserve the final heights by preventing early closure of the epiphysis. So she also gave us the treatment for the central PI as GnRH analog, and for the PPP, treat the underlying cause. Professor Lamoyegun took us through pharmacogenomics and precision medicine and the future of diabetes management. He went through the introduction telling us that DM is not a single disease but a heterogeneous disease. He talked about the importance of identification of heterogeneous types and genomic makeup of individuals with diabetes, which is important in precision medicine. He went through the classification of diabetes, and he also took us through different clinical treatment algorithms for the management of diabetes, telling us the shortcomings of this treatment algorithm, some of which include that it's a one-size-fits-all, and persons with diabetes have different responses to drugs. We also talked about the subclassifications of type 2 diabetes and the variance of type 2 diabetes in different regions. We mentioned India and Europe. We also talked about the phenotypic characteristics of newly diagnosed type 2 diabetes in Nigeria as a study that is ongoing, which will give us a greater insight into the phenotypic characteristics of type 2 diabetes in Nigeria. We also mentioned the importance of precision medicine, which is now the new paradigm structured for treatment of type 2 diabetes. He mentioned the importance of profiling and risk prediction in type 2 diabetes, and bioinformatics and machine learning in genetic data interpretation in
in Nigeria. It took us through the determinants of response to medications for type 2 diabetes, types of metabolizers, the rationale for pharmacogenomics in DM management. He also took us through the ethnic variations in pharmacogenomics, pathway to personalized medicine, and the benefits of pharmacogenomics in Nigeria. He concluded by telling us the limitations of pharmacogenomics and the future directions of precision medicine in DM management. The last lecture was by Dr. Odeni, talking about adrenal tumors. He introduced different types of tumors, either benign or malignant. He mentioned that 60% of them are functional and 40% are non-functional. He talks about the classification of adrenal tumors, the evaluation of adrenal tumors, talking about history, clinical signs, hormone testing, and talked about the biochemical test, cortisol, plasma and urinary metanephrines, aldosterone, renin ratio. It talks about the importance of imaging after biochemical testing and also to rule out metastasis. It talked about indications for surgery and mentioned that adrenalectomy is the gold standard for managing adrenal tumors, and the adrenalectomy can either be laparoscopic or open surgery. He went to tell us about medical management being used for inoperable tumors and the modalities for the medical management. He also talked about incidentalomas and the importance of follow-up, which is lifelong for patients with adrenal tumors. He mentioned emerging trends and again reiterated the importance of precision medicine in the management of aldosterone, and he subsequently concluded his talk. Thank you very much.
Please, let's give her a round of applause. Thank you for such beautiful summary of what we have done. It's now time for questions, comments, queries, additions, subtractions. We'll take 3 people before we round up this session. Please indicate. Let's see your hands. We've had 3 people speak to us. We sure must have something to add or subtract. Else I'll call people. Else I'll call people. Yes, please. 1. 2 more. Two more before I call people. All right, let's have Dr. Maybe while she's at it. Others will also. Yes.
Thank you very much, Professor Denny, for that lucid presentation. I am always excited and amazed when we delve into other issues beyond DM, because diabetes is where every other physician can come and do stuff. But when you talk about adrenals and all these kind of things, then it's the meat of the endocrine person. Because we've had 4 cases now of pheochromocytoma in children, adolescents really. The first one was operated successfully. The second one was Jehovah's Witness, and they said that they will not, because the surgeon said that we cannot, you must sign that this child may need blood, and if you don't sign that the child will need blood, we will not. And it was very, very painful experience because the child is 13, and the parents said that she can speak for herself because the law and the law that protects children said that the child is not Jehovah's Witness. The child is not 16, but they said she can talk for herself, and she said that I am Jehovah's Witness, and that if God doesn't want to heal me, then if I die, I die. And we never saw that child again because it was a very huge tumor. Then the third one was operated successfully. The fourth one was operated successfully. But the investigations are huge. Those ones, we actually use urinary metanephrines. So this time around, maybe the woman was looking well in my head. So we wrote out everything. When she came back, she was crying. She said that I can't afford it, So we now had to stay with urinary. And luckily, the evidence says that urinary metanephrines in PCC also approaches 100%. So we're glad for that. I just wanted to thank you to add voice to what you said.
All right. Just two more spots. Yes, sir. Dr. Balogun. Thank you.
Thank you very much. So I said since we must say something, but actually he's just to appreciate one of the topic presentations, particularly the one on precision medicine. I really think conferences like these is for us to know that even though diabetes is common, the way things are now, it's not as simple as that. It's complex, it's heterogeneous, and you'll be surprised about so much going on in terms of application of precision medicine to both the diagnosis, typing and subtyping of diabetes, even the common type 2, type 1. There's so many types, and here in Africa, we even have ones that are yet to be discovered. It's really an area, that we have to be looking at. 3-4 years ago, we did a very good review about, in my opinion, Professor Loco will remember this. It's published about how precision medicine can actually help us in this. It's wonderful listening to it, and I enjoyed that part a lot. Thank you.
Much, sir. Thank you, man.
Thank you very much, sirs, and thank you very much to the speakers. I just also want to add to what Dr. Wodo said. There's something called early puberty in girls, especially in the negroid race. I don't know if she mentioned it. Unfortunately, I wasn't here when she presented. Girls that are negroid, that are blacks, have been observed to start blooming, to bud their breasts at age 6, 8. Even though the general consensus is that any child that buds before age 8 is precocious. But it's been observed that there are so many Africans or African Americans that begin to, develop breasts between age 6 and 8, and they are normal, they're not precocious. And so there's a phenomenon called early puberty, not precocious puberty. Just to add to that. Thank you.
Thank you very much. Well, we would need to close this. You have a question?
Not really, Chairman. Just to say that those investigations can be very, very expensive. Now, that is where we come in as specialists. We must look inward and select which one will be useful for us to make diagnosis. But we must make diagnosis, whichever way, because they've gone everywhere. And so they are back to us. So we can't say because they can't afford that 250,000 naira test. For example, that is how much to do a GAD antibody for diabetes in SynLab. Okay. Exactly. So what we need to do is we now have as experts to now look inward. If we've listed 100 tests that must be done to make a diagnosis, if you can just look at which one can I do that I'll be able to defend anywhere in the world and say, with this, I am sure this is the diagnosis, and that's the way to go. We don't forget that we come from a place where our resources is developing. I won't say resource depleted. We are developing. Thank you very much.
We call ourselves resource limited. Distinguished ladies and gentlemen, I think I'll take this one standing up. I want to say a big thank you to all the presenters. It's been an enriching afternoon, and I'm sorry. I thought we have actually had lunch. I never knew we haven't. That was when I said our ATPs have increased. Please pardon me. But I must just add that at the University of Lagos, there is what we call the Center for Genomics of Non-Communicable Diseases and Personalized Healthcare. And what do we do there? We do things like what Professor Lamoye says. We do not run routine tests, but we rely on a lot of grants to do proper research. We believe there are new and emerging biomarkers, which we must look at, especially because most of these drugs do not do what we want them to do. They're not cut out for us. Our genome and genomics were not taken into consideration in formulating these drugs, and we've heard that today. I want to say that one of us here, Professor Fasamade, is the lead of the Metabolic Syndrome Thematic Group. So if you need to speak to us, please speak to him. I lead the molecular oncology. I tend towards prostate cancer, but there are several other thematic areas, and you can actually let's speak together. But I'm glad to say that sitting here is Professor Magbagbiola. About 25 years ago, she encouraged us, those of us with our PhDs under her, to come for this meeting. And we thought, oh no, it was a bloody waste of time. But 25 years down the line, I'm glad I'm here. She gave me a PhD. She was my PhD supervisor. She's retired. So you're looking at a 75-year-old woman. Don't be deceived, but I'm glad she's sitting next to me. I get inspiration. You know the support. Women supporting women. This is such a beautiful table. Only. She taught him chemistry. I'm glad. I'm glad. So it's a pleasure to have us seated here. And so, distinguished ladies and gentlemen, we've been told to bring our mentees, but I'm glad my mentees are here. My mentor is also here. Please give me a round of applause now. Thank you very much. Do have a lovely afternoon.